Arganissima, New York. Your exotic skin, hair, and beauty source, and your one-stop shop for all your natural and organic skin and hair care, featuring authentic organic Moroccan oil and prickly pear seed oil and much more. Bringing you only the best, straight from the source and proudly produced in the USA. So what are you waiting for? Shop today at www.arganissima.com. Arganissima, New York. Your beauty is our...
Folks, welcome back to the iHealth channel, iHealth Radio. We're your host, Hurricane H. New day, new show, new topic as usual, a new interesting topic. I try to always bring something new. And in the realm of health and health settings and medical and even writing, we've talked about a lot of different topics. And today's topic is going to be a little bit of an interesting one in the aspect of it, because it's something that sometimes we shy away from. It's not a topic we talk about a lot in the medicinal world and or even life, because it's taboo almost, but it's an interesting. And I have with me a guest who will actually guide us through this discussion and enlighten us with it. And her background is a very interesting one, because she is actually an anesthesiologist, and she is an actual doctor, award-winning doctor. And also she is an author, a novelist, and she writes thrillers, and she uses some of the stuff that she knows in the medicinal world into the write-ups and the writing. And we want to hear about all that. So it's a pretty interesting discussion we have. And really it's something that, I'm calling it actually living well with a living will. So that might give up, the discussion today, or give in, what the topic is. But without any further ado, I have with me Tammy Uliano, and she's all the way from Florida, and we're going to be having a great time. So Tammy, welcome to the show. How are you?
I'm great. Thank you very much for the invitation.
Oh, my pleasure. My pleasure. You and I connected, and I just loved the theme, and I know we're going to talk about your book, and we definitely want to talk about your book specifically today. But before we get into all that, let's talk about your background and as I mentioned, award-winning doctor and your specialty specifically. And then we're going to talk about the topic of the hour, like the living will, I guess, and the proxy and all the other stuff,
okay,
which you
great.
cover in your book. So talk to us.
I'm a Floridian since childhood, and went to University of Florida for undergrad and decided to go to medical school. Primarily, I wanted to do research, and then somewhere in there realized I didn't want to kill mice my whole career. So I just finished my medical degree, and then I started working on full-scale human simulation that was being invented there. And I got to be part of the program, and it was awesome and amazing. And I fell in love with obstetric anesthesia. And so I spent the next 15, 20 years doing research in that, and teaching using simulation, which was brand new at the time. So that was a great experience. And that features in the book a little bit as well. And then interestingly, I said that our medical students needed their own textbook for anesthesia. And my mentor said, okay, let's write one. And I said, we can do that. And so he and I sat down for the next couple of years and wrote an introductory textbook. And when we finished it, this is an 80-year-old German man. He said, let's write something else. And he decided we would write a mystery, which was a blast working with him to try to write a mystery. But unfortunately, he fell ill and passed away before we got very far. But I had the bug then. So I stepped back from some of my administrative stuff and started taking classes to learn how to write fiction. And Fatal Intent came out of that and published last March. So it was a long road. And I've had a few twists and turns, but it's awesome. I was at the right place at the right time. It was time I'd reached my goals in medicine, and I'm still practicing. I love taking care of patients, love teaching, but doing research, I was kind of bored with that. And I really don't like being an administrator. So I played to my strengths and pivoted away from all of that toward something better.
Wow. Thank you, Tammy, for that great intro. And that's a lot of stuff, that we've captured in a very little moment here. The word, the book, the name, Fatal Intent. I mean, that's deep, and we need to dissect that, in its own. And I know we're gonna have a half of this show is probably gonna be just that, if not the majority of the show. But I did want to just ask about, you mentioned obstetrics, anesthesia. Can you just elaborate on that for people that may not understand, what that entails?
Yeah. So primarily, it's not my only assignment, but when I'm assigned to labor and delivery, we're taking care of women in labor. So a lot of labor epidurals to relieve their pain, and then cesarean sections. So a lot of anesthesia for that. And then we're a tertiary care center. So we get the super sick pregnant ladies. So we'll go to the intensive care unit and help take care of them there, and take care of them long before their baby's going to be born, helping to manage their blood pressures and things like that.
Well, thank you. I mean, again, it's just, I know some people are like, well, that's an obvious, obstetrics, anesthesia. I mean, you could put one and one together, but you're right. I mean, you just covered a couple of things that we might not think of, and one, obviously, epidural stuff. I've seen that in action personally, and it is not fun. I mean, it's very intricate in a way, because you have to have the right stuff, and it's a very sensitive area where those needles go, and you can't make a mistake. You can't make a mistake with that stuff. It's very dangerous. But you're right, it does alleviate the pain, and it helps the delivery to a smoother way for a lot of folks. And so I mean, thank you for doing that, because a lot of moms would probably be like, yes, without it I couldn't have done it, right? So thank you for that. And then also, like you said, for those people that have literally like C-sections and things like that, certainly, you can't do it awake. So you have to be under, and you guys come in to do that. Now, I know anesthesia is not easy, and it's an art in itself, and there's a lot of risk, and can you just, and this is, I know it's not the core topic of today, but if you just want to ease up, because people sometimes are tense about it, they're afraid, and, what can you tell people just to ease their mind about anesthesia as a whole? I mean,
Sure. It's incredibly safe, especially for healthy people. The ones that really get us our blood pumping is the super duper sick people whose hearts aren't pumping very well, or whose lungs don't work very well, or who are having super major operations. But for the vast majority of people, it's incredibly safe. And obviously you're going to be nervous. It's the loss of control is very upsetting to people. But it is very, very safe. And our big things are putting you to sleep and waking you up, but also managing your pain, because we're trying to get away from narcotics. So the things you might get offered are lots of what's called regional anesthesia, where we put numbing medicine around nerves that are the ones that are supplying the surgical area to try and keep you from having pain. So similar to epidurals, but we do the nerve blocks in different places. And those are really great options. And other areas of research that are important is things like people talking about having postoperatively having mental thought issues, cognitive dysfunction, we call it, where they just feel a little bit foggy longer than you'd expect. So that's a big area of research. But obviously talk to your anesthesiologist. You'll see them preoperatively and then again postoperatively. And we work very closely with the surgeons. It's a wonderful profession, being able to take care of people when they're at their most vulnerable. But if we do it right, you largely don't remember us. So, so it can be a little bit thankless.
Well, well, thank you. One thing for sure, you guys literally help lives and save lives, because I don't know what we'd be doing without anesthesia. In a lot of surgery and a lot of different procedures, you can't possibly operate, and you make it smooth enough that people go through it, and they eventually recover before they know it. I mean, they're good, they're better. I mean, they still have to have the recovery point, post surgery, but at least the whole. I mean, without it, imagine people being opened up, and the sutures and everything while they're still feeling the pain. I cannot possibly imagine, which probably centuries ago that was the case. And
it was, yes.
Yeah. So you guys are really, it's a great thing that you guys do out there. And I don't think we could live without, anesthesia any longer in this universe we live in. So again, thank you for that, for every one that you've said.
You're welcome.
Thank you. And so the other thing, you mentioned something about the simulation, I guess, right? Are we talking about like augmented reality stuff, or are we talking?
We haven't gone there yet, although that's certainly someplace that we should be doing it. What we started with was we actually have a mannequin, a plastic mannequin, and we at University of Florida, they developed lungs that actually move up and down and have breath sounds and consume oxygen and make carbon dioxide just like a normal person. And there's pulses that you can feel, and you can take his blood pressure and all those sorts of things. He has a mouth and everything for the residents to practice putting in breathing tubes, and we can make it so they can't get it in, and then they have to practice what you do next. And so we use it for giving them real life scenarios that's actually full immersion as far as they have to do everything. We can't just say, hey, what would you do if the blood pressure goes down? They actually watch it. They see the blood pressure go down. They have to pick the right medications and administer them properly in the right doses. So it's a nice way for teaching medical students and residents before they are actually given that situation. And especially for rare things that they might never see, it's nice if they can practice them a couple times before they graduate and then see them in private practice.
Wow, that is impressive. I mean, something like that. I mean, it's got to be an experience. And first of all, just the technology itself. I mean, the fact that you have something that is not alive, but it's almost alive, it's
Right.
alive, it's like, it's amazing. And I know there's a lot of discovery and a lot of research that takes place in medicine. And today we are just, cutting edge in a lot of areas. Obviously, there's more. I mentioned augmented reality, which is coming up more in terms of anatomy and things like that, but I think it can get even better. And I've seen some stuff that's out there that people are dabbling with, so it's getting there. I mean, soon you can almost simulate a whole operation without even having to have a real anything in front of you, but still be able to do all the dice. I don't think they do that already. I think I've seen something.
We have robotics surgeries. We hate them, but they do them.
Well, I mean, listen, it's one thing, I mean, to trust a machine, and then the human factor is an important factor. I'm assuming you can't get rid of that. That's the most important part. But hey, some people say like the future will be with robots. I don't know. It's a challenging, world we live in, and things are moving fast. So we'll see how that plays. But until then, we appreciate, medicine and the doctors out there and surgeons doing it, in and out, and really being with us. So now let's take it to the next level, and the writing. You being, writing, first of all, a book about, how to do anesthesia and all that stuff. Originally, that was your first, I guess, besides your studies and educational stuff. I think that was the first actual book that you put together.
It is, yes.
Right. So that got you going.
It did, yeah. I called it Do No Harm while I was writing it. And then when I found a publisher, they said that title was too common. And if you look on Amazon, there's several books and a movie called Do No Harm. So Fatal Intent as a title came out later. But yeah, the idea for it came out of life. It was always something that fascinated me, how to end, you put your dog to sleep when their quality of life is poor, but we can't do that for people. And when I was a kid in elementary school, there was Karen Ann Quinlan, which some of your listeners may remember way back then in the 70s. And she was a person who was in a persistent vegetative state, and there was disagreement in her family about whether she should be allowed to die or kept alive. And we did a debate on it in my class, and I don't remember which side I was on in the debate, but it stuck with me that was a very challenging issue. And I, during my extremely atheist, I know everything sort of college days and early medical school, I thought, you just say they aren't going to live anymore, and you invite everybody to the bedside to say goodbye, and you give them an injection, and you're done. And that just seemed very black and white to me. And as you grow and get a little older and more mature, you realize there's a lot more gray in between. And so I don't have it quite so clearly in my head what the right answer is, but I know that it's something that families need to discuss, because I have seen some very sad end of life situations where there's no clear guidance from the patient, and the family disagrees. And what an awful time to be unable to communicate properly with your loved ones when one of you thinks that dad wants to be unplugged and the other one says, no, there's still hope. And it just doesn't have to be that way if people will have these discussions well before the time when that information is needed.
Well, thank you, Tammy. I mean, that is a very, very, very difficult decision for anyone. I mean, we live life happy, and everybody, really, we enjoy life and we don't want to live life. And, for the person that is at that point in bed, then, sometimes they're not completely gone and they still have the ability to discuss hospice, let's say. And then you got the folks that are already like intubated or already under, machinery and stuff. And, you don't even know what's the next move. And I'll talk about a situation that happened to me. And I had to make that decision actually in my life.
Oh,
Which is a tough decision, and I don't mind sharing it, but it's a very, very difficult place to be, and so it takes faith, it takes a lot of different things, and sometimes science and faith together to actually make that call, and it's not easy, and you don't want to let people go. That's the other part. As a son, for example, in my case, it was difficult. And luckily, I don't have brothers or sisters. It was just me. So it's a little different. And I didn't have to talk to uncles and aunts about, to make that call. But sometimes, to your point, it could be a very divided discussion and a huge debate. And I think, one of the things we want to extract today is the fact that the ability that each alive person should have their will and their proxy, the surrogates and all the stuff and all the documentation in place to determine what happens. Like, for example, one thing that happened, and what I'm referring to is my dad. He was terminal and with prostate cancer, and we were told that he had a few months to live, and then of course he was doing good, and then all of a sudden things started going very, very sideways quick. And he was coherent, but I mean on and off, and then he got paralyzed, and then that was getting worse. And so luckily I had a proxy, so I had the documentation, and I had already a DNI and DNR, and so that was important. And when the time came to from the hospital, and they had to make the call, do we want to plug him or not? That's when my problem happened. And one thing that they said, if you do not submit your documentation, we will just do it. So I mean, for our listeners and our viewers, I mean, it's a very impossible situation when you have the authority, but then somebody else now is challenging you. If you don't submit this document within the hour, we're going to do something that you're not even clear about. And like, do not touch him, do not mess with him, do not anything. I have documentation, I have full authority. Here's the documentation. Do not resuscitate or intubate. Now, this discussion happened with my father before, and we made sure that we have all the documents and stuff. And I even talked to my colleague. Like, I'm in the healthcare, so I have doctor friends, and so I talked to them, and I got some of their advice, medical advice. Even the oncologist at the time, he says, listen, only a few months to go, let him live the way he is and enjoy his last days, in no pain. And we had them on the medication and stuff. And so when it happened, we had that, but actually I had to literally fax the documentation to the hospital, and that same morning that they hospitalized him, and that was actually his last couple of weeks. So they said, he's doing not good. Do we want to do this stuff? Do not touch him. Allow him to live his life, and if he's going to pull through, he's going to pull through. If not, there's nothing we can do about it. And so that was it. And ultimately, they never did. And he lived a couple of weeks, on his own, and eventually, he passed. But that experience, it was an eye opener, because had I not have the document with me, and we didn't have the actual health proxy available, they would have actually plugged him. And then now I'll be stuck with the decision. Is he alive? Is he dead? Is he good? What am I supposed to do? Right. I mean, and it is very difficult to tell, because there's brain waves, there's other things that happen, and mechanically speaking, he'll be functional. But, I mean, from a religious aspect, is his soul still there or not? I mean, so right. There's a whole debate with the religious aspect of it. So it was a very tough time to make that call before, but when it came to it, I had to make a decision. Now, that's easier than other people, because some people don't have that option. They put them into the machine, and then now you have to decide when you unplug. It happened to my best friend, and his mom, was in the machine, for about a week, and they had to make the call. And it's very difficult to make the call when you don't know. You always kind of hope that that person's still going to pull through, but do you really know that they're still there or not? And that's something that even science today doesn't really 100% know, because they can tell you, we see a little wave, they're responsive to stimulus, whatever, but what does that mean? It's electrical signals. There's many other factors that can, be interpreted as such, and therefore you're not. And so it's a decision that is very difficult. So again, from my experience, it's tough. Now, in your experience as a anesthesia is where you go. To your point, you said for an animal, we can put them to sleep and peacefully and they go. And some people can actually challenge that and they say, what? Well, isn't that lethal injection? It's a capital punishment in the criminal world, right? So obviously there's more to that. I mean, some people can debate, religious, science, sometimes, both those things, get convoluted, and different opinions and different views and angles can change the dynamics. But really it's the importance is we need to make sure that people have some sort of documentation in there to avoid what you just said. When there are 5 kids, I mean, I was the only kid and the only one, so I made the call. But if I had other brothers and sisters, I probably would have had either an argument or fight, or maybe we have never been able to figure out, in
Right.
time, when I'm too late. So I think there's 2 points that I just covered. One is the documentation, the other one is the decision making and knowing. So, but in your experience, when you wrote the book, I'm sure there's real stuff that you've put in there. So why don't you share with us some of that? I mean, I just kind of digress a little bit on my own story, because I think it fills in exactly in the book, concept. But tell us about the core piece of the book and the elements there and the recommendations within the book.
There's one story in there that's a true story. When I was an intern, which is your first year of training after you finish medical school, when you're on call at night, you're covering for other people. So we would have an A team and a B team, and at night you cover both. And one of the patient's families asked to speak to me, and it was not a patient of mine. So I had a little note card that said what what her diagnosis was and what the situation was and any labs I needed to follow up, whatever. So I read that and went to the bedside, and it was an older African-American woman who had suffered a stroke and was on a ventilator. And the expectation was that it wasn't going to be a good outcome. And so I went in the room, and her whole family was at the bedside. And one of the sons asked to talk to me, and he said, "Why do you get to play God and turn off her ventilator tomorrow?" And here I am, fresh out of medical school, going, I'm not turning off her ventilator. But we had that discussion, and at the time I gratefully had some decent training in it. And so I explained to him, God gives us the ability to save people and develop the ventilator and breathe for people, but he also gives us the knowledge to know when that's not useful anymore, and that we actually can keep her body alive almost indefinitely, but it's not life. And then obviously I said, you need to talk to your actual doctor in the morning. But so I put that scenario in the book, and that's a true one. The idea of somebody, so the laws currently, there's a few states where you can choose that you want your doctor to give you something to help you kill yourself. So it's physician assisted dying. That's available in certain states, but the patient has to be able to self-administer that. So for a patient like this on a ventilator who's not able to communicate, that's not an option. The only option is to turn things off. And if, as sometimes happens, they don't actually die, because the ability to breathe is handled by a very primitive part of your brain, not the conscious part that we think of as being a person, but we call it the lizard brain, the part that'll work no matter what. They might not die when you turn off the ventilator. And then what do you do? Now they're on tube feeds, right? Because they can't eat for themselves, but they aren't going to die just by turning off the ventilator. And so then you have to withhold food for them to die, which is one of the things that I bring up in the book, and how how does that look? Watching someone starve to death is they're not awake and complaining about how hungry they are, but still something to have to watch, because it can take a week, right? We give them usually water, but we don't give protein and glucose and sugars. And so that's sort of what we talk about in the book is, and I try to not preach. I try to say, here's one person with this opinion and one person with this opinion, and I don't say which one's right. I try to I think it's very intellectually challenging to take a murky issue and find rational arguments on all sides and try and make them all sound rational. So I find that fascinating and fun, and so I hope that's what I do in the book. But the main point is that the person needs to make their wishes known, and obviously it's important when you're terminal to make that clear, but bad things happen, and those are probably the most heartbreaking ones are when a young person who is expecting to live a much longer life has something traumatic happen, and they've never had that discussion with anyone, and then a grieving family is stuck trying to make those decisions. And what you'd really like is for somebody to say there is zero hope, and we just can't say that. We don't have that sort of science behind us, but when we can say it's highly, highly unlikely, and then people cling on to that little tiny piece, and it makes their decision making very, very difficult.
Thank you. I mean, you're covering a lot of different, real deep elements here, and I want to just take a moment for breaking them down a little bit. So the first thing is talking about living, right? Because someone is intubated, is that really living? And then and there's two levels of this. To your point, some people do pull through, and they become better. I mean, they go to coma, whatever, and then they come out of it and they just live a happy life. And so you can't dismiss that option. And that's the technology and why it was developed, and it works. But then you have the other where they don't pull out, and through this whole ordeal, and then all of a sudden you're stuck with the actual dilemma, right? Then you have the other piece is that the fact of hospitals and systems in general, when someone is in front of them, they make the call. I mean, intubating and stuff is not something that usually, unless there's a DNR or a DNI, doctors will proceed and hospitals will proceed. And that's the other part, in the likelihood of someone elderly, who is hospice and, maybe terminal, it's a little obvious and there is more discussion about it and there's prep to it. But to your point, someone suddenly just gets into an accident or something and they're plugged, and there is no directives. There's nothing else. There's nobody that's actually making the decision. The hospitals will proceed with the clinical piece of it, and therefore they're going to put that person under, the anesthesia and plug them in and do all the stuff, the ventilators. And now, to your point, families are going to have to make call. And you're right. You're never going to say, "Oh, there's no hope," because you can't take that. And you can't say that they're going to survive, because now you get sued if they don't. So which way? It is a pickle. I mean, you can't really do anything about that. That's a tough one. And you're right. It's just, it becomes difficult because everybody hopes that no matter how bad the situation is, that something's going to turn. Even there's just a bleep like, "Oh my God, it's happening," right? And that's exactly what people have, that hope. To me, when I gave my story, it was a very difficult, because like in my mind, like, did I make the right choice? Should I have, had him, get plugged? But, I mean, I have a different opinion about religious and life in general. So I had to believe that, if he had pneumonia before and he made it through, if he's going to make it, he would have made it anyway. So therefore, if his body is going to give up, there's nothing we can do, and he's not going to leave until it's time. So there is that, some rationale from the religious, belief and the faith, but scientifically, I also knew that, there's going to be a point where I'll have to make that call, and before, after. Now, my dad didn't put the stuff. The only thing, we made sure that there was a documentation of DNI and DNR, and so that was it. So that helped the process. But you're right.
Do your listeners understand what DNR and DNI are?
Probably not. So do not resuscitate and do not intubate. So basically, you're not plugging someone. You cannot give them a tube, and you cannot really do anything to CPR them. It's over. Right. So you let them be, and they can live. And that happens in accidents, for example. If you have that, it's over. They're not going to do anything for you. They just bring you in, and it's over.
Yeah. So it's really important to make sure that when you get admitted to a hospital, that they know your wishes at my hospital, they ask every single time, which feels a little bit weird when you're getting admitted for something minor and they're saying, if you were to die, do you want to, and you're like, what are you going to do to me? But the other thing is, if you're going to have surgery, and this comes up in the book, generally we put people to sleep, and when we put people to sleep, we put a breathing tube in, so that's intubating. So if you have a DNI, then we sort of rescind it for the surgery, and then once we take the breathing tube out, it's reactivated. So that gets a little bit confusing to some people, but those are really important things to make sure are clear with your caregivers.
Yes. Well, actually, just as a note, since you covered something there, I wasn't clear about. So when people are going under anesthesia, not in general, they don't get intubated on general, but some cases, I guess, not every case.
The vast majority get intubated if you're having surgery, especially if it's in your abdomen. We pretty much always have to intubate you, or if you're having brain surgery, we pretty much always intubate you.
See, I wasn't even, I didn't even think so. I mean, I thought they just put a needle and, you get to sleep, but I didn't realize that. So again, for audiences, news to me.
That's why you have a sore throat after anesthesia, because we put a tube in your throat.
See, that explains that. And,
Yeah.
I wasn't aware. So thank you for clarifying that. And so that was interesting to hear. And again, folks, but you're right. When you go to the hospital, my mom went to surgery. My wife had the surgery, and they did go under anesthesia, and that's documentation. They tell you all the stuff that you have to sign before you actually get in under. And there's also a risk. I mean, there's no hospital or doctor that's going to give you 100%. We're going to put you out, and you'll be fine. There's always a waiver. There's always potential risk, when you go under. So it's a challenge. And so that when you accept it, and sometimes you have no choice,
Right.
you have to go to surgery, and you just just give in. It's okay. If I come back, great. If I don't, sayonara, everybody, forgive me for what I did. Then hopefully I didn't hurt anyone, and that's it, right? It is a tough, I mean, I'm laughing about it, but it's a tough, place for anyone. I mean, and this is not for someone that are hospice and they're end life, or towards their terminal in stages. This could be anyone, at any given age, things can happen to anyone. And that's life in general. I mean, really, we live. And, one of the main things that we have experienced recently is the pandemic. How many people, they were breathing normal, the next thing they're actually in the hospital and they're intubated. Some made it, some didn't. And that's reality. And a lot of hospitals, I mean, the first thing in the pandemic we heard about was ventilators. It was the biggest, tool that's been used for this pandemic. It was scarce. It was, some states didn't even have enough of them. Hospitals were, overwhelmed. But that was the protocol. You come in, if you get into oxygen, whatever, and the next thing you know, if it's not happening, we need to make it happen for you. And so now that's, and some people didn't have a say in it. Parents were not, able to get into hospitals. Folks didn't even have access to the hospitals. People were sent into the ER, and then that was it. They get admitted, they get processed, and basically, and I mean processed in terms of the hospital process, not in a bad way, just to be clear. So, but that's the thing. And then they get into the hospital, and now there's a decision made for them in a way. And a lot of folks didn't have the right to even get in because they could not even get to the hospital.
Yeah.
It was a tough time, and last year was just, or the couple of years ago was bad. I mean, even last year we still had some difficulties. Now it's less, crazy. And even with Omicron, it's better. But go ahead. Sorry.
It's crazy at my hospital still, but the summer with Delta, that was the first one that really affected pregnant women, where we were having a lot of pregnant women with COVID and some very, very bad outcomes. We're doing a little better with Omicron, but we're still having a lot of pregnant women in the ICUs. And get vaccinated, please get vaccinated, even if you're pregnant. It's really important.
Wow. I mean, well, thank you for sharing that. I mean, that's, I didn't put the analogy in terms of pregnant women and I guess the impact on the babies and all the stuff. I mean, that's
it's real.
Wow. Again, but you're right. Delta was a tough one. I mean, Delta was just as bad as, probably even sometimes worse. I mean, I did not have the original, COVID. I mean, I went through it for over a year and a half until last summer. and it was it. But luckily I had a mild,
That's
I
good.
guess 2 or 3 days, at home, nothing, bad. But I've known people that have been hospitalized, and my mother-in-law actually got hospitalized for a whole month, and a lot of people around her passed, literally, it was a rough, time. And Omicron, to your point, is not as bad. But we have to be aware that it's still out there. It's still risky, and people are actually still getting, hospitalized, and some, less, I guess, fatal, outcomes, but nevertheless, it's there. So let's go back to the fatal intent. So you said something very deep about the decision making of someone that's alive. We all have. I mean, I believe that we should all have a will, personally. And people think like, well, I don't have to. I'm still healthy. We just have it. Doesn't matter. I mean, that could be anything. And part of the will is who is going to be making decisions for you, right? And
Yes.
that's your proxy or surrogate, and then or power of attorney, whatever the case may be. That depending on how you choose to do this with your, I guess, law firm or lawyers. But at the end of the day, it's important because that's going to determine a lot of things. And to your point, if something happens, this is like the organ donor piece, right? I mean, some people put that in place in advance, so that it's in documentation or whatever. This is actually even beyond, because now you have to, give somebody the authority over you, and when you are unable to really make that call, and that's a difficult test. Now, here's all, like to your point earlier, when you have people that have multiple folks, how do you pick one?
That's a challenge. Yeah. So legally, the person responsible for you, if there isn't one, is your next of kin. So your parents, unless you're married, and then it's your spouse. And if none of them are available, then it's your children. If none of them are available, then it becomes your siblings. So they have a very strict hierarchy. But if you have a healthcare surrogate named, then they become the primary decider. And they recommend that you have a primary and a secondary for that, because if that person was in the car with you and died, then who's going to make decisions for you now? And so that's, again, something. The forms are very, I think, self-explanatory. They are state dependent. And so if you go to different websites to try and download the forms, it's not hard to find them, but you do need to make sure it's the correct one for your state. And so you name a healthcare surrogate, and that person needs to know what you want. And even in addition to that, I think you need the document that actually says, I would like tube feeds, or I absolutely do not want tube feeds, that sort of stuff. And it's really, I mean, that's been available for a very long time, but somewhere around only about a quarter of Americans actually have any sort of document outlining what they would like, and designating someone to make those decisions.
Well, thank you, doctor, for that. One thing, let's clarify, because I think the proxy is someone that just can do things. Even if you are available, they can still do that, make the decision equally as you, even when you're conscious.
It depends. A healthcare proxy cannot. I mean, it depends on the definition that is in the document. Most of them will say, and only if you are incapacitated to make that decision, which has to come from a physician who decides that you're incapacitated. There are other proxies for other purposes, but a healthcare proxy is different. But
surrogate is really that they basically become you in decision making, period.
Yeah, and they have a different name depending on which state you're in.
Right. And again, and like in New York, for example, the healthcare proxy, even takes precedence, I think, over the power of attorney in this matter, because it's the ultimate document for health. So every state is different. You're right. And but I just wanted to, maybe if there's any difference in terms of what those terms mean, but they kind of do the same functionality. The key is someone is got the full capacity and authority to make a call and a decision on your behalf when you can make one. And again, it's a tough one. Now, you did mention something interesting earlier about some states having the ability to allow people to almost basically kill themselves or terminate, their life. And and also you mentioned something earlier about like when that person came to you when you were still in your first year, and like you're playing the power of God and you can't decide and whatever. That's a tough one, because again, it's like Can we plug? Can we unplug? Can we plug? That's like somebody's like literally, if you're religious, you will think about that. Like, who are you to actually make that call? Only God takes life, right? And so therefore now it becomes a very challenging, proposition when and you're right, you're not making that call. It's the family has to make the call. But then for the folks that make the decision themselves, when allowed by the law in the state, and they just basically, they don't want to live in pain, and it's, they just want to end it. That's where it becomes a very touchy, because now they're making that decision, but their family may not be for it, and they'll have to go to court to get the okay for it. I'm not
actually, if you, in order to qualify for physician assistant death, you have to be deemed competent. So the family has no say. You decide that you want to do this, and you have to sign something, and you have to sign it 2 weeks later, and you have to have a written document that says exactly what you want. And 2 physicians have to concur that you are, first of all, terminal within 6 months, and that you are of sound mind to make this decision. And then they give you a prescription that you have to get filled. You have to be able to take the pills on your own. It can't be administered by someone else. And it's very strict to try to prevent any sort of slippery slope to it. But it does bring up the interesting concept of right to die versus duty to die. So I live in a state where I can choose this, and now I'm worried about being a burden on my family. So do I feel obliged to choose this? And so it's just super interesting how different ways you can take all of this. And the other thing that's interesting is it's been legal in some states for quite some time, and it's really not being used all that much. So, and of the ones who request the prescription, only about a third to a half proceed to use the prescription and end their lives. A lot of them end up dying of something else in between.
Wow. Well, I mean, listen, I don't think anyone at any given day would assume that that's something that they want to have to call. Everybody hopes that you go to sleep and that's it, and it will be an easy one, right? And that's not the reality of things. I mean, people, again, I know in medical terms, there's the word of expired. I am not I'm partially not a fan of that word when it comes to humans, but it is the word that's used in hospital settings and healthcare. But no one wants to think about them like they have an expiration date, and they're basically like you can, and it's funny because I have seen this with my eyes, in ICUs and stuff. When people pass, I mean, there could be 5 people, 6 people laying there, dead, and the staff is just, and they've seen enough that it's okay, just a routine day. But for most of us, that would be like devastating to know that there's someone that's laying next door that's dead, right? So there's a lot of this. It touches on the religious, the moral, the ethical, and then the science and really what the practice is. So there's a lot of opinions about it, and you're right. When you have more people that can make a call, or they just have to be part of the decision, and no one is going to allow. Well, not no one. I'll stay corrected here, because I know that there are cases where, to your point, people have made that decision. They went through the process and they did actually end their life. But it's tough for them, and usually because of pain, and they just can't suffer anymore. And you're right. I mean, earlier you mentioned something about even when you unplug someone, they have a tube, you're feeding them. I mean, are they really living? Are they feeling pain? You can sedate them all you want, but I mean, we don't know what this whole thing is, and it's probably hurting their children or their family members, because seeing someone in that stage is not going to be easy, right?
Absolutely. Yeah.
I mean, it's just not, I mean, this whole topic, like I said, it's going to be real touchy for people because it's sensitive, and people no one wants to talk about that. I mean, in general, that is not something that, people want to just, have a discussion about, but it's reality, it's life. And every living thing dies, unfortunately. And it's, again, part of reality. We have to be aware of it. And no one knows how that ends. And, understanding what the laws of the land are, and, what you have, to your point, the rights and the duties and all the stuff for everyone, person, or their family members, and really understanding those dynamics can make a big difference. So now let's talk about, I mean, first of all, the fatal intent, the book name is just interesting because this is like really your intent to terminate life. And this is not criminal. I mean, not talking about an fatal intent in the criminal world, but this is more like in the health settings or the healthcare settings where someone is really sick and they have to have the full intent that it's happening, or even not them, someone else has to make that intention that they're gonna unplug someone that's already in their, a tube or intubated, and that's a tough one, right? So what else in the book do you really kind of highlight in terms of people, parents, or actually kids, because this could go both ways. And I think parents is even harder, because sometimes when someone is aged, people have, to your point, at least they know it's going to come to the time where there's going to be a separation and somebody's going to, depart. But when someone is young and vibrant, and the parents are always excited, I want to see my kids grow, I want to see my grandkids, and so on and so on. And all of a sudden something happens. That's a very tough one. I think that changes the dynamics from one age group to the other, because if you're a parent, no one wants to see, of course, we don't want to see anybody hurt, but when someone is older and they lived a happy life and long life and they get into that, you don't want them to suffer. So you almost make peace with that. Mm-hmm. But when someone is young, you can't. I mean, and again, I have seen young people depart, in life, in my own surroundings, and, it happens every day. And it's always devastating for the parents. And sometimes when someone goes to the hospital and now the decision is made that they have to be plugged and they're in the machines and no one knows if they're coming back, that's tough. So what do you tell the folks? I mean, is there anything you say in the book to maybe ease up based on experience, or at least, some of the practices out there?
One of the first rules of fiction I learned was never hurt a child. And so I focused all of my badness, for the most part, happening to grownups. There is one scenario and so it's things that we see. So the child who's got severe mental delay, who's not functional in any way that we recognize as functional, not necessarily in pain, but not able to communicate in any meaningful way, not able to control their body. And then we're doing procedures on them, but it's not really improving their quality of life. And so at some point you wonder why we're doing this to them. It may not hurt them, but it's not helping them. And maybe it is hurting them if it's just such a challenge to decide where in there is, so do no harm is sort of one of our mantras. And sometimes doing something is more harm than good. But who makes that decision? And so I do address that a little bit in there. But you're 100% right. It's watching parents deal with sick children is just heartbreaking. And the place I see it mostly, because I don't do a lot of pediatrics, but I do obstetrics. And so we see tiny babies that are born too early and parents making decisions about aggressiveness of resuscitation on a baby who's got a really tough road ahead of them. And it's, God willing, you'll never be in that position. And obviously the child can't make any decisions on their own in that case. So it's entirely the parents. And sometimes I wonder if it wouldn't be easier if the doctors just said, this isn't reasonable. We're gonna, cuddle your baby. We're gonna let it pass, instead of saying, what do you want us to do? Do you want us to go full court press? There's a 0.1% chance it'll work. What parent is going to say, nah, let my kid die, right? I mean, it's almost cruel to put it on the parent, but in our society, this whole patient autonomy is to that, which I 100% get. But the ability of people to grasp the odds is excruciatingly small. It challenges everybody. I mean, challenges the doctors to try and quantify, and it challenges family members to grasp the gravity of the situation and what that child is going to go through to try to keep them alive for a not great outcome. I don't do neonatology for a reason. I wouldn't want to have to be the one trying to counsel people on that.
That is tough. And I have to say, you said something about our society and things, but really, I mean, even because of the way the laws are, any healthcare service provider would never, get into that decision. I mean, it has to be given back to the actual patients or the family, because all you have to say is the wrong thing. And now, once this is all settled, then you have a whole slew of malpractice and lawsuits, and it gets crazier. And no one wants. That's why, unfortunately, no one will ever give you. To your point earlier, nobody's going to give you 100% of anything. There's always a chance that it's not going to work, and that actually works both ways, because it can give hope and it can take hope, or it can scare people at the same time. And that touches on the subject of now faith and religion, because there is an ethical part. I'm sure there's a lot of debate about this topic, and it's not, I've heard it, I've seen it. It's a big deal. And so even when science meets religion, sometimes there's a clash. It's been this way for centuries. But when it comes to the topic of life, depending on the beliefs and stuff, like we can't do this, only God takes life, and, you can't make a decision. We can't block them, and so it becomes very difficult. Was there anything that you've covered about that, concept, or at least how to deal with that conflict?
How to deal with it? Not really. Hospitals, at least all the hospitals I've dealt with, have people of various faiths on staff that will come and help the family deal with from their religious standpoints. We'll offer, when we don't expect babies to do well, if I know that the family is Christian, I'll suggest that we try and get someone in to baptize the baby if that is something they would like, that sort of stuff. In my experience, the people who have a very strong faith actually deal much better with all of this than people who don't. They, not 100% obviously, but many of them find meaning and solace that is difficult for other people to grasp.
Well, that is a great point, Doc, because you're right. Someone has, again, I give you the example. In my case, I know that life and death are together, and there's a time where you have to accept it, and we all depart at a day or another. And so I kind of made that call based, like I said, I had friends in the medicine and the clergy, and I got both advices and I was able to make that sound decision. But you're right, and you have to accept it, because if you have faith, that when it's time, right? And so you're right. There's also the acceptance of the ordain or the destiny, right? And other, contexts, it may not be like, why my son, why my parent, why this, and it becomes a question mark, and now it's a debate, and no, do whatever it takes, and I think there's another aspect now that happens, and we can touch about that. I'm not sure if it's in the book, but now the cost. I mean, when someone is in a hospital bed and they're plugged, I mean, that's a lot of dollars and that are being paid for that particular bed and supply. That's a big debate too.
It is. And one thing we would never, I'm in a hospital that we don't ever turn patients away. We're not a private hospital. We're the funded in part by the state, and so we offer care to everyone regardless of what their ability to pay is. And I have very rarely had a patient say, well, I'd like that, but how much is it going to cost me? Now that discussion may occur outside of my hearing, because I'm not, but I've never heard a patient, having a baby say, no, let's not put them in the ICU because we can't afford it, right? That's not a discussion that occurs. And so we end up with extraordinary healthcare costs. And you could argue from a societal standpoint, where should that money go? Should the money that it costs to save one super preemie baby that could vaccinate an entire state's worth of children for a year, where is the cost supposed to be? But we also know that as humans, we see a single person way better than we see a population, right? So the whole thing about a train track where you have to divert the train away from one child, but it might kill 5 people, and everybody chooses to divert the train because that one little kid, where you're actually costing more lives, except you can't see them. So it's sort of the same issue. There's been a lot of studies on end of life and what the money costs are. And even just having these end of life discussions that we've been talking about really have a huge impact, because just like you were saying about your father, you probably prevented some care that would have been very expensive. And so just in the last 30 days, I pulled up one study. They compared families where the patient had had that discussion with their caregiver or who hadn't. These were cancer patients. And in the last 30 days of life, the median cost for a patient who did have that discussion was $1,000 healthcare costs. And if they didn't have the discussion, it was $23,000. So we err on the side of acting if we don't know not to. And so we end up spending a lot of money on what is probably undesired care, but we don't have legally, we don't have any choice. We have to intubate and put them on a ventilator and admit them to the ICU and do all those sorts of things. And later we might turn it off, but that doesn't change the fact that it cost a lot of money to do all those things. So that goes back to the same thing about having those conversations, and maybe there needs to be better legislation that makes it easier. There was some back when I was in medical school was not intubating the same as withdrawing, as turning off a ventilator. And they decided that those were the same, that it was okay for us to put a breathing tube in because we could turn off the ventilator, because we didn't want to have to make that decision right when we were about to put the tube in. And so that helped a lot, but there's still a lot of angst amongst physicians, not so much my anesthesiologists, but critical care docs about what do you offer? When is it appropriate to say this isn't going to help? And making families have to navigate all of that.
Well, doctor, I mean, it's amazing what you're talking about right now is very deep. And one of the things, the life, what's the value of a life, right? And there's no one that can actually give you a value for life. Everybody is valuable, right? And there's no money that can buy a life. And so therefore, the decision is beyond that. That's why people are like, do whatever it takes, just do it, right? And like in my case, right, it was not that I did not want to save my dad. I mean, if I knew that there was a chance that he would, that would have made a difference, but from the medical, doctors that I talked to, from the fact that, we know that he was already like, in his real end days, there was no, and like I said, then I consulted with the fate part of it. And at the end of the day, like if he pulled off the first time from the pneumonia, he would have pulled off for that one. And that was the easy way to almost comprehend it, or at least to digest it. But some people, would not make that call, and because they want to do the best, and they try, right? Again, I'm living with that. Does that mean I made a mistake? No. I mean, did I ever have a doubt that I was the one that didn't give him his full ample chance? No, I don't even believe in that, because I believe it was his time. Right. But that's me. Some people will agree. Some probably people will disagree. If it was my dad, I would have done whatever. Let them plug him in. Well, you could have, and that's exactly, you could. But the problem is now you have to make that call to pull that plug yourself. And now, trust me, that would not be that easy.
And the outcome eventually would be the same if he was terminal with cancer. So, and
how long is that? So not only he will be in a bad position, or at least suffering somehow, but you're also going to be suffering, because the uncertainty of the fact that he's there, he's not there. You go see him, you see him in pain, and you're there, and you can't do anything about him. That makes it very difficult, and people may not even realize what that means until you have someone that is laying in there and you can't do anything about it. And again,
the death watches are awful, where people are sitting at the bedside because they don't want them not to die alone, but we have no ability to say it's going to be 3 days from tomorrow, or it's going to be in 2 hours. It disrupts their lives if they have to move it to the hospital from out of town and put themselves up in a hotel, and it's an awful system. Well, awful situation.
It is. We don't wish that on anyone, and frankly, I hope that people don't have to go through it. But in reality, it can happen, and it happens, and people are going through it every day. And the pandemic had made it very clear that it happened, and happened to millions, not just in specific categories of some diseases. I mean, that was like pandemic wise. So everybody everywhere around the world almost experienced it, and it's a tough place. And again, the cost itself, as you said, when I made the call, I didn't even think about the cost of the hospital stuff, because you had insurance and everything. But you're right. Some people may not have the insurance, for example, if they private pay, and they would probably sell everything. And, I would also, normally if you have no choice, you'll do whatever it takes to save your family, right? But still, it is still a cost that somebody is actually having that burden.
Even if you have insurance, it's still a
Exactly.
cost that money isn't going somewhere else. Yeah.
Exactly. And so the question is, was it necessary? Was it going to make a difference? Did we have to? And there's also the debate that there is the abuse part of it, like, why not, let's plug them in. I've heard that debate before, when some people say, well, the hospitals may just take advantage of it and keep someone plugged because that costs more, revenue. There is that discussion, and there's that extreme theory out there as well. So you're never going to make people satisfied in any way. There's going to be one on this side, there's going to be one on this side, and the reality is it's a tough place. And you're right, we don't have a final way that we can measure this, like, no, this is done, it's over, we can, or yes, we can do this, and there's going to be results. So there's always that chance that people would have to make the call. I think the core message today, and I'll give you the final statement here to tell us what your message would be from the book, or at least what would you advise people in general. For me, I'm getting it is just make sure you get at will, make sure you make those assignments, I guess, while you're still healthy and at any given age. So what would be your, I guess, final advice to the listeners and the viewers right now?
Really, really kind of the same. Actually, if you go to my website, which is tuliano.com, on the resources page, I have links to various places I thought were the most explanatory of getting those documents completed. But at the very least, just have the conversation, however painful it is to do. Put it on your calendar and have that conversation. And then every 10 years, have that conversation again, because we know people's wishes change and evolve based on new diagnoses and new living situations. You get married, you get divorced, whatever. But just think about it and pray about it if that's what you do. But it's much easier if these decisions are made prior to the time it's needed.
Well, Doctor, that's as deep as it gets. That's actually as simple as it gets, honestly. And you do have the resource. So I will actually share. I already shared the link on the description of the show. So it'll be available to people. They can click in and see what. And again, depends on what state you're in. You can actually certainly get the information for that state. You can download those documents. And, again, the healthcare settings, we actually offer that. So when we talk to people, and we always have that available, someone wants them, especially for long-term care. But again, I know it's available also in hospitals. You can literally get one from any of the providers out there. They have them. And so it's out there as at least the healthcare process. And by the way, it's not just for end of life. That could be for other things. Just making decisions while the person, for surgery and things, or if they're not able to do things, even for insurance purposes, believe it or not, that document works because someone can actually represent you and make decisions on what coverage you would have. So we use it actually for the insurance purposes, but I know
that's great.
Yeah, it's available. So, but it is what it is. I hope that we've learned a lot throughout the show. Doctor, you've been very valuable to us in sharing something different in a needed subject, because people may not want to discuss it, and we did. We touched on it and we brought it up to them, and now it's people are listening, watching. They should be able to at least have an idea what we're talking about and what they should be doing. They don't have to take advice, but hey,
right.
Hopefully
always.
they do. Hopefully they do. Well, so Doctor, thank you. It's been a pleasure, and thank you for all the insights here. And I appreciate the time here, folks.
Thank you for having me.
It's a pleasure, folks. Thank you for watching and listening on iHeartRadio. Your host Hurricane H. We'll be talking soon. Different topic, different show, different guest. Bye for now.